Hello and welcome to another live broadcast with MedStar Health. My name is Mishan Bowman, and today we're live with Dr. Sandeep Jani, director of our Hypertrophic Cardiomyopathy Clinic. He's also a board-certified cardiologist specializing in advanced heart failure with MedStar Heart and Vascular Institute. Today we're going to be talking about hypertrophic cardiomyopathy, or HCM. It can be difficult to pronounce, but it's the most common genetic heart condition. So if you'd like to learn more about its risk factors, symptoms, treatment options, and more, keep watching. Share this broadcast with your friends on social and ask us your questions in the comments. We're going to take some time to answer those as well. So welcome, Dr. Jani. Thank you for your time and spending it with us today. Yeah. Before we get started, could you tell us a little bit about yourself?
Sure. So I'm a cardiologist and I specialize in heart failure and cardiomyopathy. So see lots of folks with hypertrophic cardiomyopathy, other cardiomyopathies, as well as patients with heart failure here in Baltimore at Union Memorial and at Franklin Square.
Okay. Thank you very much.
Yep.
So let's get into some of our questions. So first of all, what is hypertrophic cardiomyopathy?
Yeah, so hypertrophic cardiomyopathy, if you literally translate those words, hypertrophic means thick, cardiomyopathy means heart muscle problem. Okay. So hypertrophic cardiomyopathy is where the heart muscle is thicker than you would expect for the circumstances. Okay.
And it's a genetic condition, so is it something that you could be born with typically? Or?
Yeah, so we think it's a genetic condition primarily, which means it can run in the family. You're not necessarily born with a thick heart, but you may be born with a propensity to develop a thick heart, which can develop at any time during your life, most commonly in the teens and 20s.
Okay, that's very good to know. So how is it usually diagnosed, and who diagnoses it? Should you go to your primary care doctor or a cardiologist?
Yeah, so it's really diagnosed by a cardiologist with various imaging tests, which include an echocardiogram, which is an ultrasound of the heart, and often a cardiac MRI, a heart MRI. Your primary care doctor may pick up clues such as an abnormal electrocardiogram, EKG, but really it's the cardiologists who have to look at the pictures of your heart to understand if you have hypertrophic cardiomyopathy.
So what causes hypertrophic cardiomyopathy?
Yeah, so, well, again, we think it's genetic. So it's something that's related to your DNA. Okay. It has nothing necessarily to do with your lifestyle, what you've done, where you live, what you eat, what kind of exercise you do, any of that sort of stuff. It is just something that happens, and it's not the fault of any of the patients who have it. It just sort of happens. So you're born with a propensity to develop it, and then some people will develop it as life progresses.
Okay. Now, with that said, are there certain people who are more at risk or prone to developing HCM?
It's a good question. So we think it's the most common genetic heart disorder, and we think it affects maybe 1 in 500 people, which you can imagine is a lot of people. Right. And it seems to affect all races, all genders. Everyone sort of equally is at risk to have it.
Okay. And how can someone tell if they have HCM? What are the symptoms that they should be aware of?
Yeah, good. So many patients have no symptoms at all. And so many people go through life without even knowing they have it. Some people will develop what I would call non-specific symptoms. So shortness of breath, chest pain, feeling their heart racing, sometimes dizziness or passing out. Very rarely, some people's first presentations will be a heart rhythm problem so severe that they potentially die or nearly die. Wow. But that's pretty rare.
Okay.
But usually it's those symptoms, sort of shortness of breath, chest pain, palpitations, sometimes leg swelling. And some people will never have any symptoms at all.
So at what age do people usually show signs of having this condition?
It really can happen at any point in your life. Okay. Most commonly, the changes we see of the heart occur in the teens and 20s, though it can occur later in life as well. Symptoms can occur at any time in your life, really. And lots of people are diagnosed when they encounter the medical system for something else. They need surgery. They see a primary care doctor who happens to do an EKG, and may get diagnosed even without symptoms.
Okay. Thank you very much for that.
Yeah.
If you're just joining us, thank you very much for tuning in. We're live today with Dr. Sandeep Jani, director of our Hypertrophic Cardiomyopathy Clinic, discussing the most common genetic heart condition, hypertrophic cardiomyopathy, or HCM. So if you'd like to learn more, keep watching this video, share it, give us a like to let us know that you're watching, and ask us your questions in the comments. So we're going to take some time as well to answer those. So continuing on, you mentioned that it's possible that someone could not present symptoms. So you can be asymptomatic and still have HCM. Is that correct?
That's right. In fact, even patients who are diagnosed with HCM, many of them are asymptomatic and really have no complications through their life, though there are potential complications that I think we'll discuss in a little bit, right?
So are there different degrees of severity with HCM? Could you explain that a little bit?
Yeah, of course. As with all heart conditions, your symptoms could be very mild to severe. And a lot of that just depends on how you feel. So some people will be very short of breath, some people will have episodes of passing out or heart rhythm problems that can be dangerous. And other people will have minor thickening of the heart, or relatively minor, I guess I should say, and really live a pretty normal life.
Oh, that's good to know. So if you have HCM, does that mean you need to significantly limit strenuous activities like sports or other types of exercise? I figure if you're short of breath, then you might want to change that.
So the general guidelines for HCM used to be that exercise is a risk for having a heart rhythm problem that could be dangerous and cause somebody to pass out or rarely pass away. I think in more recent years we've been talking about potentially allowing moderate levels of exercise. So those could be things like jogging, extreme exercise, or high intensity activities. We still suggest that people limit because we still think that there's the risk of having a heart rhythm problem that could be dangerous in that setting.
Okay, so like 30 minutes of like moderate activities. Okay.
Yeah, and we have ways to put people on treadmills and monitor heart rates and their oxygen consumption and sort of provide guidance as to what a relatively safe level of exercise can be.
Okay. So say you're an athlete and you're diagnosed with HCM, perhaps you didn't present any of the symptoms before. Can you still participate in sports anymore, or do you have to like limit that activity? What changes do they have to go through?
Yeah, I think it's a shared decision-making sort of process in terms of understanding the risks of that individual patient, the risks of the sport that they play, and along with whatever association or team that they're playing with. So I don't think it's an absolute no. And a lot of it depends on what sport they are, at what level they participate, and sort of the risks of that individual person. Unfortunately, there are some athletes who are in very vigorous sports, such as football or something like that, that will need to scale back or won't be able to play at the level that they would like, I think. But I think a lot of people can still play depending on what they do and how they play.
Right. So I know we mentioned that it's HCM is the most common genetic heart condition. So could you explain that genetic component and say, for instance, if a member of my family, like my mother, for instance, has HCM, does that also mean that I should get tested or screened, or am I at a higher risk for getting this condition?
Yeah, so it is a condition that we think runs in families. Now, that doesn't mean that if no one in your family has had it, that you can't have it. There are people who have normal families and still have it. If it is in your family, that does not mean you're absolutely going to get it, but that means there is a chance. And we recommend that all first-degree relatives of patients who have hypertrophic cardiomyopathy have their hearts screened. and that's clinically screened, which means that they get an EKG and an ultrasound of the heart.
Okay.
Depending on their age, depends on the frequency of how frequently they need screened. So teens and people in their early 20s get screened more frequently, sometimes once a year, or if not more. And then adults tend to get screened every 3 to 5 years. Okay. In addition to that, we can do genetic testing on patients with hypertrophic cardiomyopathy, and we can look for DNA mutations that may have predisposed them to having hypertrophic cardiomyopathy. Mm-hmm. We don't look for everything. We don't look for long-lost relatives. We don't look for other disorders, but we look for genes related to the heart.
Okay.
And not everyone will have a gene mutation, but some people will. And then we can talk about whether it's appropriate to screen family members with DNA for DNA mutations as well. Mm-hmm. Again, if you have one, that doesn't mean you're going to get it, but it means that we have to pay attention. Okay. There are lots of potential implications to getting DNA screening, so we do that with our genetic counselors who can thoroughly explain the process and the testing.
Great. That's a great segue to my next question about genetic counselors. So could you explain what their role is in the whole treatment process for HCM?
Yeah, absolutely. So our genetic counselors are really important, and they do a big part of sort of family screening. So they take a very thorough history of the family and try to identify people who may be at risk or had it in the past. In addition, they explain what genetic testing means. The results may not be always 100% straightforward, and so they help to navigate that process of what the results may or may not mean. They also can explain the implications of being tested for DNA, having your DNA tested, especially in patients or especially in families who don't have actual disease, who have normal hearts, but their family member may have hypertrophic cardiomyopathy. So it's a really critical piece to sort of navigate that entire process.
That's good. So if you have HCM, is there anything that you could do to stop it from progressing, like lifestyle changes like you mentioned, or maybe diet, exercise, anything like that?
So most of the treatment we have for HCM is related to symptoms right now. So if your heart is going to get thicker, I don't have a way to keep it from getting thicker right now.
Okay.
So we do routine monitoring to look for the complications related to HCM, which are several. One can be heart rhythm problems that could be dangerous. The second is that sometimes the heart has to work extra hard to pump blood out of the heart, and that's the medical term for that is obstruction. So we work to manage that. We work to make sure folks don't have heart failure. If they do have heart failure, we manage that appropriately. And then in extreme circumstances, some people may need catheter-based procedures or surgeries to help improve their symptoms. Saying that, there are potentially new medications on the horizon that are not yet approved but have been tested at this point and may help the long-term management of both symptoms and how your heart functions with HCM.
So with that said, does HCM increase the possibility for additional heart conditions or health conditions?
So HCM comes along with other heart-related issues. And so a lot of what we do is routine monitoring to make sure that we're paying attention to and tracking those possible heart-related issues and complications. And early intervention in those possibilities can have significant benefits. So there are some people who unfortunately are at risk for dying suddenly from HCM. So for example, in those examples, for example, we talk about placing small implantable defibrillators under the skin, which kind of act like a life insurance policy.
Yes.
Or the other way I describe them is kind of like a sprinkler system. Like they don't put out the fire unless there's a fire, right? So same sort of thing. But we do routine monitoring to keep track of all of these things. If they have significant symptoms, then we try to address those symptoms and improve upon them as best we can.
It's good to know. We have a question from our audience. I figure we can plug this in at this moment from Roseanne. Thank you very much for sharing your question with us. She asks, is HCM different from dilated cardiomyopathy?
Yes. I take care of both of those groups of people. Dilated cardiomyopathy is where the heart gets weak, and over time the chambers of the heart enlarge in size.
Okay.
Hypertrophic cardiomyopathy is where the heart muscle itself gets really thick. 90+% of patients with hypertrophic cardiomyopathy do not ever develop a dilated cardiomyopathy, though there are a very small portion of hypertrophic cardiomyopathy patients who go on to develop a dilated cardiomyopathy.
Okay.
So the primary difference generally is that the dilated cardiomyopathy, the heart gets weak and big. The chamber size gets big. In hypertrophic cardiomyopathy, the heart is usually a normal strength.
Okay.
It's just the muscle itself is thickened.
Thank you very much for that answer, and thank you, Roseanne, for submitting that question to us. So going back to HCM and its connection with other possible conditions, what are the different courses of treatment for HCM, and how can a patient manage this condition?
Yeah. So the initial treatments are medications, and they're medications to help slow the heart rate down, relax the heart. If you have heart failure, which means you're holding on to extra fluid, we get rid of the extra fluid. And that's the initial sort of stages of treatment. Some people do fine with just that. Sometimes we have to escalate the medications to try to relax the heart more, to slow the heart rate down. And if medications fail, then, and you have obstruction, which is where the heart has difficulty pumping blood out of the heart to the body, then we start talking about, do you need catheter-based procedures that can thin out the heart muscle? Do you need surgery to thin out the heart muscle? That's really a minority of patients with hypertrophic cardiomyopathy that need that, but some of them do. But usually the first step is medications. There are also a group of patients with hypertrophic cardiomyopathy that I talked about before who are at risk to die suddenly. And those patients, we recommend implantable defibrillators, which is essentially a small, it's like a pacemaker, it's a small thing that goes underneath your skin, and it just is monitoring your heart for electrical storms that can cause you to pass out, pass away. And if you have one of those, it goes into action and gets you out of it.
Oh, yes. Speaking from experience, my dad had heart conditions as long as I could remember. He had that defibrillator. Saved his life. So thank you very much for sharing that information. So what type of doctor or doctors should a patient see if they have hypertrophic cardiomyopathy? For instance, your cardiologist, genetic counselor, any other specialists?
Yeah, I think they need their primary care doctor, and then I think you need a cardiologist who has experience taking care of folks like this. Here at Union, we've sort of built a lot of structure around being able to look at these hearts with echocardiograms in very specific ways, do the MRIs, the cath lab, where they do the catheter-based procedures, is well versed in these patients. So you definitely need a cardiologist who has experience with hypertrophic cardiomyopathy and sees a fair number of them. In addition to that, you may need other specialized cardiologists as well, like electrical heart doctors or heart surgeons or heart doctors who do catheter-based procedures, sports cardiologists. So generally, it's a head cardiologist, sort of a main cardiologist, and then a bunch of other cardiologists who help manage it as well.
So truly a team effort.
It's a team, absolutely.
Yeah. So anything else that you'd like to share about HCM, the treatments that are offered here at MedStar Union Memorial, anything like that? Well,
I think we've done a good job in trying to create a structure where we can get as much information about your heart if you have HCM as we need.
Right.
So that's getting really good pictures of the heart, both on the ultrasounds and echoes, as well as MRI, having other folks who have seen many of these patients to understand the electrical problems and the catheter-based issues. And so I think we've built a team that can handle a lot of these issues as well.
That's good.
In terms of therapies, I think the vast majority of people usually are on medications, and not necessarily all of them, but most of them can live a pretty normal life. And it's a condition that can be managed. It's a condition that just needs routine monitoring to make sure we're not missing things and to make sure that we're dealing with all the issues that arise. And then we try to partner with patients and discuss all the risk benefits of various procedures and various medications and try to come up with a decision about how to move forward.
That's great. Thank you very much.
Yep.
And that wraps up our broadcast. Thank you so much, Dr. Jani, for joining us today. We really appreciate it. And thanks to all of our viewers for tuning in, sharing your questions with us. And if you'd like to schedule an appointment with Dr. Jani, please call 410-554-6550. And for more information about what you've heard today, please check out the link in our comments. Thank you very much. We'll see you next time.